nurse. We all know her well. And she has a master's degree in community health education from SUNY Brockport. Mary taught at Brockport for 15 years in the Department of Health Science. Then at the Rochester VA, she served as a geriatric nurse care manager. Retired, Mary currently is, I don't know how you can say she's retired. She's the co-chair of the HL2 program at the U of R. She's the chair of our Rochester Accessible Healthcare Task Force. And she's also on the boards of both the HLAA of New York State, the state group, and also of our Rochester chapter. So Mary, if you're ready, we'll turn it over to you. And our technologists just have to get this thing going here. So thank you all for coming, and thank you all for listening, and we will definitely carry on with these in the future. There we go. Okay, Mary. It's all yours.
Okay, I think we're on now. I have a couple comments to make. One is don't miss the picnic. It's catered by DNR Depot out in Leroy. They're a fabulous little restaurant. They come and cook the chicken right there, and it's a great time. And there'll be door prizes. The conference in September, this is our first real venture with the state. And we already have about 80 people who are registered. So again, not to be missed, there are all kinds of features that are going to be there. And I do the silent auction. Those of you who remember the walk, we'll have one of those there as well. I am so happy to be here because this has troubled me for a long time in terms of healthcare and hearing accessibility for people with hearing loss. I really perceive this as the beginning of the beginning, and you are in on the first floor. I want to tell you a joke first that came yesterday to my email box. And it was a woman who went to the doctor, and she said to the doctor, you know, I'm passing gas and I can't smell it. Seems to be odor free. And I don't hear it. So it's very quiet. So he examined her and said, I'll see you back in a couple weeks. So she went back for a follow-up and she said, doctor, I can smell now. And he said to her, okay, that was a sinus infection. Now we're going to work on your hearing. Okay, I'm going to let that roll for a second because I'm not so sure how funny that is, because how many of you have gone to the doctor and the doctor has said to you, when was your hearing checked last? Outside of a couple of us, probably never. It should be part of the health inventory. Just like to ask you, have you had an eye exam? Have you been to the dentist? For the ladies, have you had a mammogram? And some gentlemen, have you had a mammogram in the last year? There should be part of the inventory about hearing. Have you had a hearing test? Have you been rechecked? If you have hearing aids, how old are they? If you go to the hospital and you are and you have a broken arm, before you leave, the arm will be splinted or casted. They will give you instructions about how to take care of that. They will give you a referral to an orthopedic surgeon for follow-up. If you have a hearing loss, what you get is nothing. Nothing. So I'm hoping that these are our first steps. And I'm hoping that we do this again in the fall, but we have some representatives of our healthcare systems who can address some of the things I'm going to provide to you today in terms of information. If you remember David Letterman, he had a top 10. I have a top 20 for why you should be involved with this call to action. And I'm just going to read off a few of them because I'm sure it will hit home. For your health insurance provider, your payer source, they will be interested in this information. There's also compliancy issues for ADA, as well as JACO, the Joint Commission for Accreditation for Hospitals, as well as HIPAA, and HIPAA related to particularly telehealth. HIPAA is the Health Insurance Portability Accountability Act. If you go to the doctor every year, they're required to provide this to you when you sign off that you read it, and you probably didn't. But that's what this is. It's about confidentiality. Patient outcomes will improve if we have accessibility for people with hearing loss. Satisfaction will improve. General health will improve. The costs will decrease. Hospital stays will be shorter because you have communication issues that have been addressed. Provider satisfaction. The doctor got it right the first time, and you got it right from the doctor that he's happy or she's happy that you've been treated and you are well again. It also will provide a hearing loss as part of the problem list. I worked at the VA. For the health problem list for veterans, hearing loss ranks number 3. It ranks number 3 in terms of the frequency of hearing loss. So it needs to be better addressed for health problems for the general population. We have not been doing this. There are a number of things that I'm going to provide to you in a moment, but I want to kind of set the stage for this. In 2020, it was a virtual research symposium that was virtual for anyone who wanted to go on and look for HLAA National. And I was particularly interested in because of hearing and healthcare. Nicholas Reed, I was so impressed with this fellow. He's obviously a doctorate, has a doctorate in audiology. He's on the faculty for the Bloomberg School of Public Health at Johns Hopkins, which you know is #1 in just about everything. And I was quite taken with some of the information he provided. Let me demonstrate some of the things that incidentally, Nicholas Reed is also working with Dr. Frank Lynn, who is an otolaryngologist. He's a cochlear implant surgeon. He's an epidemiologist, and he is approachable. He was on the board for HLAA a couple of years ago, and I've met him a couple of times. I actually have his phone number in my phone directory. I mean, he was that approachable. This is prevalence, and the older you get, the more frequently you are likely to have a hearing loss. Based on that, if you look at the pink section here, this is the number of people who actually get hearing aids who have treated hearing loss versus people who have a hearing loss. Those percentages are really quite low, like around 20%. So there are a lot of people with hearing loss who are walking around who don't have hearing aids. No surprise, no surprise. Would you move this forward to number 16? I want to talk about this because I was so taken with this information. This is the difference in cost between people who have hearing loss who are treated and those who are not. The costs are 46% higher for people who have hearing loss. The next one, Lauren. The next one has to do with 30-day readmission rates. What happens if you have Medicare and you are discharged and readmitted for the same diagnosis within 30 days? Medicare will not pay. Hospitals do not want to know that. They do not want to have to take that on the cheek in terms of expenses. The next one, Lauren. The utilization rate is much higher, around 47% for people who have hearing loss, who are untreated versus those who are not. And the next one has to do with costs, and that is $22,000 more to take care of people who have hearing loss who are untreated. Okay, those were my slides for the moment. Here I have one more to go, but it's a ways into the production. The other information that came across from Nicholas Reed from that 10-year study was that people who, the worse your hearing loss, the higher your dissatisfaction with the care you receive when you are receiving it, whether it's inpatient or outpatient, and also the longer the delay for you to decide you need to have care, which means it's probably going to be more expensive because you waited longer. Okay, you are the consumer. Nicholas Reed, I was so impressed. He said, you are the consumer, you are the payer, and you are not getting the health care that you deserve and that you are paying for. Saying that you have a hearing loss is not enough when you go to receive health care and you say, well, I have a hearing loss. And what will that person say to you? That person will say to you, that's okay. And I say, for whom? It's not okay for me. But it's a little startling when somebody responds like that, because I'm like, okay, I'll pay attention now. Okay, the call for action has to do in many cases for communicating what you need. Saying you have a hearing loss is not enough. What do you need to do to make sure that those communication lines are open? Okay. I'm back to the other screen now. I have two programs here. Okay, here we go. All right. I'm big on top 10, but I got 11 this time. Okay. It's important that you communicate what your healthcare needs are. I have to tell you that I had a conversation with one of our local otolaryngologists, and I told him about this task force and about accessibility for people with hearing loss. And he poo-pooed me. And I'm like, what? And I thought, okay, be calm. And he needs more training. And that's what this is about. He needs more training. I do want to say that I need to acknowledge Elaine McCaffrey. Elaine is on virtual. She is president of the Chicago chapter of HLAA, and she did a program last May, and it was about hospital safety. So this is really kind of going into a different path, but I think it's the one that we need to take. Are you there? Okay. The first thing is when you walk in, there are personal communication barriers, and I'm talking about that mask. You lose 5 decibels with that mask. My hearing loss is at 80, 85 decibels. That 5 decibels is really important to me. So, you know, Ford Motors last year went ahead and took off their assembly line and started making clear face masks because of COVID. And I don't know what happened to that, but I do know that they're out there. And I know RIT has them and TID uses them regular. And so we need to make sure that we're asking for them. And I did ask for them at Rochester General. Okay. Okay. Other environmental communication barriers. Oh boy, did COVID do a number on us. That plexiglass that's between you and that person with the mask on, oh, I don't get anything at all. My comprehension is close to 0. So there are things that you can do. Whether you're checking in and they ask you, they're obliged to ask you all of those questions about, have you been anywhere? Have you been exposed? Do you have a fever? Yada, yada. Okay, you can almost recite them by heart. And hopefully you understand everything and are responding appropriately. Rochester General supposedly is going to get rid of those plexiglass barriers. I don't know about URMC. I suggest that they post those questions so you can at least read them, that they're in large print. I also suggest that you use something called Live Transcribe. Live Transcribe is a no-charge app. It is Android, so if you have Samsung or LG, you can download that for free. It's reasonably accurate. It is almost instantaneous, and you can put it on your phone. You can have it on your tablet. You can have it on a laptop. It's free. And I said, it's getting better. It's actually getting better. Marlene Sutliff was the one who told me about this. And I'm like, this is a treasure in terms of your having accessibility with people who have the mask on, who have the physical barriers, who are too far away from me. Okay. Social distancing. Not social distancing, it's physical distancing. It's 6 feet. The cream of where you are able to hear someone speak. As soon as you start moving away from 6 feet, your comprehension goes down. So at least tell people so they know, because they don't. People don't know that you're talking to them. The safest thing to do to get someone's attention is to be close enough and tap them on the shoulder. That's non-invasive. It doesn't require you're invading their personal space, and it gets their attention, that gets your attention that someone's speaking to you. That tip sheet that Art had is superlative. If you have trouble talking with your healthcare provider, go with that tip sheet and give it to them. Give them a few of them to pass around to their staff, so when they have people with hearing loss, they know what to do. There's a lot of training that needs to take place here. If you're in the emergency room and you're sick, you really, either your hearing aids are out or they're turned off, or you're just too sick to respond. And people need to know that. They need to know that they need to come a little closer, and that you have trouble. Dan told me one time that anytime anybody came into the room, he had to tell them all over again that he had a hearing loss. But what to do? They had to be a little closer. They need to make sure they had your attention, particularly if your eyes are closed because of the bright lights and you really just want to be somewhere else. So you need to do that. The tip sheets are very helpful. I would take some so that you have spares and you can give them to other people, because everybody knows somebody who has a hearing loss. Everybody. It is the most common disability out there. I'm going to show you, when I finish with this, I'll show you the signage that was developed by Johns Hopkins. Very simple. They're able to reproduce this easily, and we could do this as part of our plan for call to action. There's also something called the Pocket Talker, and these are at the demo center. They're less than $200. The technology has improved quickly. You can use that with hearing aids or without it. If you don't have hearing aids, you can use them with earbuds or with a headset. If you have hearing aids, you can use it with your telephone switch, so that they're adaptable. And I'm not suggesting that you buy them. I'm suggesting that the hospital or the healthcare provide them to you for use while you are there. The next item is telehealth. The telehealth thing is really what got me going on this, because I really need captioning. We know that Zoom is out there, and we know that it can be HIPAA compliant and that captioning should be there. At the University of Rochester, Steve Barnett told me that no one knows how to turn it on. No one knows how to order it ahead of time or who to call. So that's another thing that we need to be aware of, and we need to make sure that it is provided to us. Because come January and there's a snowstorm, you want to talk to your provider, but you really don't want to go out. And Zoom should be available to you. HIPAA compliant, captioning, so that you are able to have a conversation with your healthcare provider. I actually proposed this in addition to the people from InnoCaption. They're the people who have the app for your phone, so that you can have captioning on your telephone calls automatically. And I said to them, what would really be nice if we could do this is that you have captioning for all of your visits, automatically turned on. Don't have to do anything. You can turn it off if you really want to. But once you have captioning, you really want it. You want to be able to confirm, to verify information with your healthcare provider so that you're both on the same page. I recommend that the provider know what you're thinking, so you have conversation back in terms of what that person has spoken to. I also suggest that this be available to you electronically. It is your healthcare. You have a right to that information. It should be sent to you. That you have a hard copy, or that you have capacity on your laptop at home to be able to print that conversation, so you have a copy. And that also the provider is able to do a cut and paste and take important information from that visit and put it into your healthcare record. Let me tell you, providers would love this. It would really save a lot of time. Lisa's shaking her head. Yeah. They would like to have this because it would save them a lot of time. At the end of the day, when they're doing their progress notes about your visit, it's already there. It would be very time-saving and accurate. So I think that that's coming. I think that's part of the wave of the future. And the InnoCaption people tell me they think that they could do this with the telephone. Aha. Okay, I'm almost done here. We're at number 7. Hearing loss is the most common disability and can adversely affect patient outcomes. As I said, when you go to for healthcare, whether it is a doctor's office or you go to the emergency room or you go to urgent care. If you have a hearing loss, it's not identified. You don't tell them, they notice you have a hearing loss, but they don't do anything to provide you with information about how to take care of that, how that you can be more responsible, more receptive to healthcare. Sometimes it's a family member who knows that you have a hearing loss, and that can be put on your health record, but we need to do better at identifying that. Number 8, if you are in an outpatient or inpatient situation, there needs to be a referral for an audiogram. We should be able to provide that pocket talker for you. You should be able to use your live transcribe, provide written information, summarize key points. So you review this with a healthcare provider before you leave, and you know exactly what you need to do. And you know when to call, when there's a problem. I think that's so crucial. If you have something that's going on, when should you be able to call them that you know, I have a problem now, this needs attention. You told me I should be calling if I have a fever that's greater than 101. So I'm calling to tell you I have a fever, 101. What are we going to do? So anyway, those instructions should be part of your outpatient or inpatient discharge. I'm talking about hospital discharge too. Again, about reading and understanding instructions, summarizing key points, and a referral to an audiologist for formal testing and a treatment plan. We are not doing this. We have not done this ever. Unless you go and think you have a hearing loss and your doctor thinks you have a hearing loss and sends you because you're complaining, I'm not hearing, or your spouse is saying, not hearing me. It's only then that you actually get a referral. I'm proposing that not only that you have that, but when you have your discharge, that you have a phone number where you can contact, that they know that you have transportation so you can get to your appointment, that you have an internet connection so you're able to have telehealth for your future appointments, particularly if you need something and you're not able to get there physically. So your phone has captioning, you have a landline, you can get caption call that will provide you with captioning if you have a landline at home. The cell phone has the INO captions that I mentioned. Transportation, that you get a list of places if you need a ride for somewhere to your appointment. Lastly here, that you have telehealth at home with your internet, computer, tablet, or phone access. And for everything every encounter that you have, they should make sure that you know that you answer the phone. I tell them, I almost never hear the phone ring. You must leave a voicemail message for me to call back. Number 11 is coming. We've been saying it's coming for some time, and that is over-the-counter hearing aids. Now, Rochester General tells me that they have employed 2 audiologists, one that they scarf from Steve Hart, and the other person I'm not sure, but it's an audiology prepared person. And so they will be testing, they will be talking about over-the-counter hearing aids. Greg Horton, who you probably know is from your TV commercials with Dr. Michael Mendoza from the health department. Greg Horton is a PAC member, and he with Dr. Mendoza are now advocating that there will be free testing in their mobile unit, and they'll be moving their mobile unit to different places in areas of need. such as places like Art was talking about. We have pockets in our community of people who have no access, don't know anything about hearing loss, don't even know they have a hearing loss. They just miss so much. So we're going to try to address that. The follow-up for over-the-counter hearing aids, I do believe that Rochester Hearing and Speech, Greg Curtin's office is planning to do that. Kudos to them for doing that. It's not going to be going to the pharmacy and asking the pharmacist or the clerk to pull off an over-the-counter hearing aid that you can access by yourself and try to figure out how to use it. Is it working? Is it something that's even going to be useful for you? My mantra is one of several. Everyone knows someone who has a hearing loss. Whatever is done that you ask that benefit people with hearing loss tends to benefit everyone. Nothing about us without us, that you campaign for yourself. This is really an advocacy campaign for communication and ultimately for training. Could I do that last slide? I think it's the one about signage. It's the one that Hopkins developed. 57. Can I do that from here? I'm coming. Let me find it while I talk. This was signage that was developed by Johns Hopkins. There it is. Can you make it big? This would go over the head of your bed. This goes. Make it bigger. At any rate, this would go over the head of your bed, and it's about communication. It doesn't say you have a hearing loss. I think it puts you at a disadvantage if you say that. Possibly that you might be taken advantage of because you're not hearing. There you go. So this is something that would go over the head of your bed. It would go with you if you're transferred. It says limit background noise. So a lot of people talking in the hall, close the door. Make sure that you face people when you're talking, that you're close enough, that you have their attention. There's small things, but they're critical for us. And this particular type signage, I think, is really important. I think we need to promote this in terms of if you have a hearing loss and you're admitted, especially to the hospital, that it could provide crucial information. I want to say something about complaining. Complaining is a good thing. Complaining means that you are paving the way for the people behind you as well as yourself while you're there. Complaining is good because if you have Medicare, you should be getting a survey after you've been discharged from the hospital asking you how happy you are with the care you received. And if you say, I'm not so much, and you tell them what the problem is, they will follow that up. And if that complaint is not rectified, guess what? They lose funding. The hospital wants you to be happy. Not only do they want you to be satisfied, they want you to be well, they want you to be discharged and stay in their arena, but they want you to be well. And all of these things will be very helpful to you. If you look at some of those numbers, between 45 and 47% people return to the emergency room because they were not cared for appropriately. Somebody's calling. At any rate, complaints are good. And the hospital wants to know, they get followed up. If they're, in addition to that, this is Joint Commission I was talking about. They accredit hospitals or healthcare based on different measures. And one of the measures is if you have resolved complaints. So you need to complain if you are not receiving the care that you deserve. Not only because of the accreditation issue, but also because of ADA. And those things should be provided to us, especially with Zoom. I'm going to open this up to questions. I know a lot of people have a lot of things to say. I don't know how much time we have. About 25 minutes. This is Lisa Brooks. This is Dan's spouse, whom we adore.
Hi, all. How are you? Just a little information like about in hospital stays and stuff like that. I'm actually a discharge coordinator at Strong Hospital. So if you're admitted to Strong or just need assistance, ask for a discharge coordinator on the unit you're on or a social worker. There is somebody on every unit, or we can actually come to the unit you're on and assist you. You want a referral? We talk to the providers and say, put this referral in and we can assist you with getting your appointments. And we work with you. What date's good for you? What time do you think we can get somebody to help you get there? So always ask for a discharge coordinator. We're there for you guys. We're there to advocate. On my floor, I know I advocate for people with hearing loss. I go and see every person, and I can tell, obviously, husband of almost 15 years, I can see if somebody's struggling. And I've actually helped a lot of people and they're like blown away. I've tried to educate staff. We need a lot of education in the hospitals. It's now needs to happen. But please, my information, you can always get a hold of Dan if you're ever at Strong. Get a hold of me. I'll even come see you and help you. Thanks.
That's good news, Lisa. I have Elaine McCaffrey from Chicago who's raised her hand.
Yes, am I able to speak? Can you hear me?
There we go.
Can you hear me? Okay, good. Mary, that was wonderful presentation. I did just want to address two things. One is last year I spent a lot of time with my husband.
Elaine, if you hold on for just a moment,
sure.
We're going to bring you up so that everybody can see you speak with the captioning. You know, please realize that to do this remotely, this is really quite the coup in terms of having the technology here at my right and left sides. Elaine, go ahead. We're happy to have you.
I admire you for doing this hybrid program. That was part of my curiosity, is to see how this will be done. So I congratulate you. 2 points regarding the hearing loss and medical people. Over the past year, I spent a great deal of time with my husband in hospital settings, all kinds of hospital settings. And my advice remains the same. You must advocate for yourself every step of the way, no matter what department you're in. The blessing was that, of course, my husband's hearing loss was one thing. Mine was much greater. And he was so direct with always putting his hand up, stop, he'd say, he was a crabby patient. I do not hear you. I have hearing loss. Talk slowly. And if they started talking quickly, he would stop them and remind them. And he knew as well when I would not hear, it was important for me to hear. And when he was too sick to advocate, I stepped in and I was ferocious with wanting to know what was said. I was to the point of almost being aggressive, but I was assertive. And even right after I got my cochlear implant activated, I was using my Roger pen and I thought I had it connected and I got right in their face with it. And I was hearing, I was understanding words. And the truth was, when it was all over, I didn't even have the connection to my Roger pen. I was actually doing this with my new CI and my hearing aid because of my advocacy. So in every stage of any appointment, if you don't ask for what you need, you won't get it or they won't know what to do. They will try, and trust me, they want us to hear and understand their words. And we just have to teach them. It's always a teaching moment with every single person you meet on the medical side. The other one side of it is as far as the Joint Commission and satisfaction surveys that they mail out or give you after a hospitalization or a doctor's visit. That is your clout. Fill out those forms, give constructive advice, and make sure if there is a problem, you call it to their attention. Because the Joint Commission, according to their rules, those surveys are how the hospitals are paid. So it's the Achilles heel to the hospitals are their surveys. And if they don't get the right satisfaction from their patients, they lose money. So that's my other tip is fill out surveys after your appointments. Thank you.
This is similar. Elaine, this is Sue Miller, and I am wondering, I'm very aware of the programs that you have put together in Chicago from the North Shore chapter and how you have had and how many hospitals, the best hospitals in Chicago, and tell us what you have done for your chapter meetings with representatives from the hospitals. It's very worthwhile hearing. It's something that we'd love to do here in Rochester if we ever could.
Was that a question, Sue?
Yes.
Ah.
Yes, please tell us what you have done for your panel discussion once a year with all of the top hospitals in Chicago.
What I was fortunate and lucky enough, of course, this started prior to COVID. So what the atmosphere in the hospitals were different when we started this program. The purpose of the program was to get the hospitals like Northwestern Memorial Hospital, Rush University Medical Center, University of Chicago, Advocate Health System, which is now covering all of Illinois and hospitals in Wisconsin. We had standalone of a small one, Weiss on there, and we tried to get a few of these small hospitals that were standalones or part of the Catholic system. Point was, we got the people on the panel to talk with each other. I started out the program, again, talking about self-advocacy, which I just did for you. And then it had questions that I sent ahead of time to the panelists, but it was just a general list of topics, truly, to allow them to say what they did have. What accommodations do you have? What do you do to help your patients? And what the beauty of the program was that the hospitals could learn from one another. And they did. And over the years, there was a tiny bit of competitiveness that was great, but there was sharing of information, systems how to get clear masks out, systems that they shared with each other once they came around to being able to get clear masks. I do point out now with the severity of the current variant of COVID that clear masks are wonderful as long as nobody has really infectious. But most of us are boosted and whatnot, but if the doctor insists on wearing an N95, the doctor is protecting himself because he or she is dealing with a lot of contagious people. That's the sad part. But I did have experiences with my husband successfully on a pre-op when they were setting everything up, that they hung a bag of clear masks on the door, and everyone that came in put one on. And I actually was assertive and stood at the head of the bed with him so that I could speech read as well. So that was one of the highlights of the months that we hung around the hospital. And, you know, I can't say that when COVID being as high as it is right now, that every doctor would feel comfortable coming in the room with a clear mask. So again, then you have to use your other tools that you have for advocacy. And it's trial and error, whether it's assistive listening devices, or whether it's your signage, or your apps on your phone, your Live Transcribe or Otter AI, whatever you use. But you've got to have a lot of tools that are available to you because there's no two systems that are the same. And those are things that the people in the hospital, at the hospital program, learned from us, because we were there to teach them. We were there not to complain. It was not a complaint session. It was truly a time for us to teach the people on the panel. So I think maybe that's enough for today, but thank you.
Thank you, Elaine. I want to say that complaints are good, but compliments are better. They want to know that they're doing the right thing. And by reinforcing and saying, oh, this was really great, and this is what else you might be able to do, is the way to get things done. And as I say, it paves the way for not only you, but also for the next person behind you. And there are a lot of us. Eric.
There. Just a quickie. My name is Eric Matson. I'm on the technical committee here. I'm an engineer. Not sure how to spell it. SPEL. Yeah. My personal experience with the hospitals is it occurs to me that telemedicine is being promoted heavily. And my personal involvement has been to try and get the folks to use captioning. Very few of the telemedicine programs use captioning, and that puts some of us at a disability. The complaint I normally get is HIPAA. Well, you get around HIPAA by signing a waiver that lets you off the hook, or you use artificial intelligence to do the translation. That way there's no third party involved. Either one of those works, but they all involve speech to text software. None of the speech to text softwares have technical vocabularies. They don't have medical vocabularies. They don't have engineering vocabularies. They don't have astronomical vocabularies. It's common speech. So it's important that, for instance, the doctor or the health provider and the patient both pay attention to the translation so that either one of them can pick up errors in translation and make sure that the communication occurs properly. That's what all I want to.
You know, as you're speaking, Eric, I'm thinking to remind you that you can have remote real time, which is the artificial intelligence. And of course, it depends on how well you speak as to how good the captioning comes up in terms of speech to text. But you also can have a live caption. And I know with the NO caption, you can request a live captionist. If you're having a phone call with someone that is crucial information for you, you can request it. And when you go on your NO caption, you make that decision whether you would prefer to have a live person versus remote. Other questions, other comments from people? Oh, okay. Elaine?
Just wanted to chime in too that with these needs is you need to ask ahead of time because they don't have, if you want live captioning, they don't have that handy. If you have a hearing loss, you need to teach them what you want and ask for it ahead of time. And then before your appointment, maybe a day before, you remind them, I had asked for this accommodation. Will you have it? And if you need someone to go with you to the appointment, to listen with you, you can say, I need someone with me. I have severe hearing loss and I need help hearing. And you can, if you plan ahead of time, they can make some clearance for that. And then as Mary said, the follow-up of telling and complimenting the individuals that have accommodated you goes a long way in teaching them that they've done the right thing. And it goes a long way.
Yeah, I couldn't agree with you more, Elaine. I think it's important that people know they're doing the right thing. Bill Crowley is up here. He has a question.
I don't have a question. I want to make a statement. I have cancer. I spent 4 weeks in a Strong Memorial Hospital during the COVID. That meant I couldn't have nobody come in and help me very often due to communication. I am bilaterally implanted with cochlear implants. When you sleep and lay down, the cochlear implants come off. You can't hear. Anyhow, I spent three and a half weeks there trying to teach people, nurses and doctors, all about this stuff. And I appreciate what you've done today, but you've only got about 1 or 2% of the problem solved. It's very, very, very difficult there. And I filled out my sheet already today. And my big suggestion is have major hospitals, Strong and all the hospitals in the area, send a representative here who can stand in my place and we can talk to them and grill them and let them know about all of our problems, because they're very, very difficult when you get to the hospital and you can't hear. It's better today, but still, you got to do a lot of teaching. And like I said, they're not complaints. You're teaching them because they don't understand. Thank you for your time.
Just so you know, I did invite people from U of R and also from Rochester Regional. I did receive a response from someone from the home care agency. I don't know if she's here today. Jessica Brito was her name. But you know, I'm going to be a little more forceful. We're going to do this again. This is the first step. This is the beginning of the beginning. So now you know about some things to ask for, some things that you should do ahead of time. I have to tell you one thing that I didn't put on the list that happened to me. I had a little unfortunate experience, had a laceration to my head. It was bleeding extensively, and I was talking to someone who at a doctor's office who called 911 on my behalf. So I was transported to RGH by ambulance, and I told the ambulance people, I said, I really don't want to go. It's too hard to try to tell everybody what my health care needs are, particularly if I'm, you know, in an acute situation. The ambulance people were very communicative with the ED people at RGH, and they knew exactly what they needed to do to talk to me. You know, they came close enough. They understood about the hearing aids and the hearing loss and the help that I needed in terms of the treatment plan. So that was one little tip. I've never really thought about it before, but I was kind of moaning the fact that I was going to the emergency room. Really, I didn't want to go for a lot of reasons, but it turned out to be an important facet of my health care.
I'd like to make a comment here if I can. I hate to make a comment. I have a cochlear implant, and I think one of the biggest things that we should do, use our accessories that we have. If you have a cochlear implant or a regular hearing aid, you can get these portable microphones which go directly through your T-coil. I was recently in the hospital just about a month ago, and I tell you, if I didn't have my accessories there, I had my mic, I had the smartphone, I was able to communicate with everybody. They had it right on the board by my bed. Patient has a cochlear implant, uses a mic, and they would come in and ask for that mic right away. So we can't always depend on the other person to be the one that's got to do all the hard work. We got to do some of that hard work ourselves. Use the accessories that are available for your hearing aid, your cochlear implant, whatever the heck it may be. You got to help yourself.
Happy birthday, Fred.
Thank you.
Thanks,
Okay.
Thanks, Fred. That's important information, particularly that mic. We need to put that on the list.
Okay, I just want to show you. I bring my my Chromebook with me to doctor's appointments, and I put it right down in front of the doctor, and first of all, the doctor's amazed. They've never seen one before. So I've got live transcribe running, and when I have a telehealth appointment, I just put this next to the computer and it just captions, and they don't even know it. But it's pretty good. The Chromebook is the live transcribe is catching up with some of the medical technology, so it hasn't been too bad. So, but it gets the point across, and I can usually make up what words are screwing up anyway. But it works for me. And sometimes when I go to a meeting, regular old meeting like this, I put this in front of the speaker, and everyone goes, "Wow!" So I'm making a point there.
For sure. Yeah, that's even better, Bruce. If you can manage to bring your laptop with you, so that you have large print, so people can read more easily. We're down to the last wire here, the last 2 minutes.
Okay.
I want to add to the mantra. That there's never been a better time to have a hearing loss than now. Because look at the technology that we have that's available to us. So everybody knows every word that's being said. And I applaud you all for coming and being part of the process.
Thank you, Mary, very much. Program. Listen, one of the things that I think we've got to do is to try to package some of this so we can approach the hospitals with comprehensive package of what we're talking about that maybe they can share with their staff. I just want to comment that this joint commission, I have a son that cleans operating rooms at Strong. He's been doing it for 17 years. And every year, about a month before the joint commission comes in, I hear that the joint commission's coming and we're working really hard because this is serious stuff for the funding of that hospital. And that's the way they work. So keep those joint commission things in mind on those feedback forms. So fill out your evaluation forms and please come and get some of these materials. We've got a lot of them. Give them to people. I'm finding I give them to people that don't have hearing loss and they always know somebody who does, you know? So just spread the word. We're trying to get the word out that we exist. We can help people out and just spread it as much as you can. So come up here and grab some. And if you need any more, give me a call. We'll get them to you. Okay. So thank you very much. And as we work forward, we'll try to smooth these things out a little bit. We'll try to get things where people aren't doing things off camera that you can't see, you people that are on Zoom, and we'll try to get to production just a little bit smoother. Take care and have a good summer. And don't forget the picnic. And don't forget the batteries.